பிரிட்டிஷர்ஸ் வெளியில போன்னு சொல்றது
Good evening, everyone. Good evening, everyone. Am I audible, sir?
Yes, you are audible.
Yes, sir.
Can we start, sir? Already it is 2 minutes late.
Yes, sir. I think we should start.
Yeah. Very good evening to one and all. Today the class is going to be on unexplained shock in emergency department. But not only in emergency department, anywhere you are working, just a patient entering into the emergency or in your clinic or casualty so-called, the patient comes to you with a shock. How we are going to approach? Because there are various types of shocks are there. So we are this going to be taken by Dr. Arthi, who is assistant professor and senior consultant in Department of Emergency and Critical Care, SRM Medical College and Hospital. She is a very brilliant and young professor. Had been cleared the DNB in, with honors, and she has done a lot of workshops for the emergency physicians as well as for the general physicians. Now she is going to take about unexplained shock in the ED. Arthi, now the mic is yours.
Thank you so much, sir, for the introduction. So I am very pleased to take this class on unexplained shock in the ED. So this type of shock is very, very common in any scenario. Even can be the emergency department, or it could be a ICU setup, or even it could be in your wards. So how are we going to deal with the shock is what I'm going to talk about for the entire 1 hour, and how to identify the shock and how to treat the shock and how to manage them in your hospitals. So let us go about the topic proper. So, as all of you know, shock is a life-threatening condition of a circulatory failure and a state of cellular tissue hypoxia caused by inadequate oxygen delivery. So, initially, this can be reversible. If you do an attempt to treatment in the initial 1 hour, it can be reversible. But it becomes irreversible when it goes to a multi-organ damage and eventually it will lead to death. So the most key important concept of shock is treating it as early as possible. So that is the main important thing that I wanted to emphasize, being all the physicians and the emergency physicians. Whenever you identify a shock, treat it immediately. Do not wait till the map goes down below 65 extra. So you have to treat it, identify the shock and treat it immediately. Okay, so it is initially reversible in the 1 hour and later it becomes irreversible. So I want to tell you in a very easy format so that you can understand this. So suppose we will imagine that you're all going to a petrol bunk to get your fuel done. So we will think the petrol pump, the machine as your heart. Okay, so now the wire, the tubing which is coming from the pump, we will take it as a vascular structures, and the fuel which is coming is your blood or your volume, and the car as your organs. Okay, so whenever this is a basic scenario, we will think, and with this we will know what the type of shock we are dealing in with. So suppose your gas doesn't pump at all, so which is we call as a heart. If it is not at all functioning well, that we call as a cardiogenic shock. So the heart is not working, the pumping machine is not at all working, that we call as your cardiogenic shock. So there is no gas at all, there is no fuel at all, so that we call as a hypovolemic shock. When there is no fluid or no gas in the pump, that is your hypovolemic shock. So when there is a blockage in the pipe structures, so that we call as a obstructive shock. So when there is a problem with the hose that is giving it to the car, so there is a problem in the hose, that we call as the distributive shock. This is a very easy way to understand what type of shock we are dealing in with. So with this, we will go to. So in shock, generally we have two type of shock. So we call that one as your cold shock and your warm shock. Okay, so the cold shock is your periphery is becoming very cold, and this is most commonly seen in your hypovolemia. So warm shock. So warm shock is mostly seen in your sepsis and your neurogenic, all kind of distributive shocks. Okay, so in the distributive shock, the major problem is your decreased in your systemic vascular resistance, and the pulse pressure will generally be wide. Even the peripheries are warm, they would be in a shock. So I think this is clear. Difference between a cold shock and a warm shock. So this is a classification of what an hypovolemic shock. So hypovolemia means some volume is being lost, as we've already discussed. So this is most commonly seen in your hemorrhagic type. So where you lost blood, or it can also be any fluid loss. So non-hemorrhagic it can be a DKA and can be an AG where there's a lot of fluid loss and all is there. In burns also, third space volume loss has been there. So we tell the hypovolemic shock as hemorrhagic and non-hemorrhagic shock. So next we go to the cardiogenic. Something happening with the pumping, that is your machine. So this could be your infarction. Most common cause is your myocardial infarction. So any arrhythmias, any kind of valvular heart disease, and your cardiomyopathy can lead to a cardiogenic shock. Next one is your obstructive shock. So obstructive is usually your pulmonary embolism, cardiac tamponade, and your tension pneumothorax. And last one is your distributive shock, which is your septic shock, anaphylactic shock, and your neurogenic shock. Okay, so now I will tell you how to deal with a obstructive shock first. Okay, so in case of any obstruction, in case of a pulmonary embolism, I think you will be able to find out how a pulmonary embolism usually presents to you with. So you can find a patient who is tachycardic, hypotensive, and hypoxic. Okay, following any kind of uh, conditions like long-standing, he would have a malignancy, long-standing immobilization, trauma, and he would have a malignancy. Those patients can go for a pulmonary embolism. It's all your clinical suspicion. Okay, next one is your tamponade. So the treatment for pulmonary embolism is using antithrombolytics and then thrombolizing them. So this one, if it is a chronic pulmonary embolism, then you go for an heparin, continuous heparin infusions and all. So next is your tamponade. Tamponade, definitely you need to do a pericardiocentesis. So and a tension pneumothorax, do a needle decompression, and after the needle decompression, you have to go for an ICD insertion. So this is how you deal with an obstructive shock. So other type of shock and how do we deal it? How do we identify it? I will be telling you. So if you have any doubts, you can stop me and ask me. So this is a chart which tells you what type of shock and how many percentage they have been in distribution for a distributive shock. So distributive shock is mostly your sepsis, neurogenic shock, and your anaphylactic shock. This is the most common thing which we see daily. It's mostly a sepsis. Every day we encounter septic patients in our ED or in our ICUs. So most common shock, which is most commonly found, is your distributive shock, which is your septic shock. Okay, then your hypovolemic shock, which is 31 to 36%. Okay, the key point in a distributive shock, it decreases the systemic vascular resistance. Okay, and there is also a decreased preload. Okay, so in a hypovolemic shock, there is an increased systemic vascular resistance. The only shock which has a decreased systemic vascular resistance is your distributive shock. So other types of shock will have an increased systemic vascular resistance. That differentiates it between the cold shock and the warm shock. Okay, so the hypovolemic shock being the next common one with 31 to 36%, and which also has a decreased cardiac output. Okay, this is most commonly seen, as I've already explained to you, in a hemorrhagic and a non-hemorrhagic conditions. Next is your cardiogenic shock, which causes increased preload, increased afterload and increased systemic vascular resistance, and thereby decreasing your cardiac output. The final one is your obstructive shock, in which you can have decreased preload and increased systemic vascular resistance and decreased cardiac output. Okay, so these are the types of shocks and their percentage of distribution. So this chart or this PowerPoint gives you a detailed description how to deal with the shock, what treatment you have to give, and how to identify them. So what is your map? So with the map only we tell whether the patient is in shock or not. Anybody who is having a map, see, generally by looking at 90-50 BP, we don't tell it as a shock. Whenever the map is reduced less than 65 only, we determine them as shock. So even a person can be a thin built person. It can be a 35 or 40 kg person. For them, the normal BP itself is 90/50. So that cannot tell that the patient is in shock. Okay, so when their mean arterial pressure is less than 65 only, we label them as hypotension. Okay, so when your map is less than 65, we term them as hypotension, and your map is mostly a measurement of your cardiac output and your systemic vascular resistance. As I've already told you, whichever condition has got key major role in your systemic vascular resistance is your sepsis or septic shock, anaphylactic shock, and your neurogenic shock. Okay, so your systemic vascular resistance is being sorry. So your systemic vascular resistance is being mostly affected by your septic shock, distributive shocks. So the treatment for a distributive shock would be starting on vasopressors. So every time whenever a patient is in shock, we will tell start on inotropes, start of inotropes. See, inotropes are conditions which increases the heart rate. We should be very clear in labeling the term what is inotrope and what is a vasopressor. Okay, so we want in a septic shock a vasoconstrictor. Okay, so we will use noradrenaline for septic shock. Okay, for a distributive shock, for a sepsis. For anaphylaxis, it is different. It is adrenaline is what we use. For a neurogenic shock, it is a noradrenaline is a drug of choice. So vasopressors are used for distributive shock, mostly a septic shock. Okay, the terms have to be very important. Whenever this has been very commonly done. So whenever a patient is in shock, start of inotropes. See, inotropes are only used for patient who has got a decreased heart rate and a decreased contractility of the heart. We are increasing the contractility. So this inotrope is generally given for a cardiogenic shock. Okay, so for a distributive shock, we will be using a vasopressor. Okay, so as I've told you, something which is affecting your systemic vascular resistance is your septic shock and your distributive shock mostly, and we'll be using a vasopressors, that is your noradrenaline, adrenaline, and your vasopressin. So something which is affecting their cardiac output. Okay, the cardiac output is a measure of your stroke volume and your heart rate. Something there is a problem with the heart rate, which is, it could be a complete heart block, a myocardial ischemia. So for that, we can use a chronotrope, which is your atropine, or we can also go for a pacing. So next one would be your stroke volume. Stroke volume is dependent upon the preload and the contractility. So something which is affecting the preload, which is a volume loss. It could be an hemorrhage. It could be a GI loss. So that condition is being treated with a volume replacement. So for example, a patient is having a AG, acute gastroenteritis. So the patient is losing a lot of fluids. Okay, so you need to replace the volume which has been lost with the volume. It could be another NS or a RL. So for example, the patient is in a trauma and losing a lot of blood. This patient, you have to treat with blood products rather than going in with a inotropes or your vasopressors. Okay, so next one is your contractility. So for the contractility, you will be using adrenaline, dobutamine, and levosomendin, or sometimes we can even go for higher ends like your ECMO IABP. Okay. So I think with this, we knew what the type of shock is and how we are going to deal with it. So now we will go for each and every shock in detail. So next is your cardiogenic shock. So we will go about with the cardiogenic shock. So this causes a reduced contractility and therefore decreases the stroke volume and your cardiac output. So this for this type of shock, we will be using, if the BP is good for a cardiogenic shock, if the BP is good, we will go about, we will give dobutamine. And if the BP is very low, we will start them on noradrenaline and then go with a dobutamine. Okay. The diagnostic criteria would be any shock with a MAP of less than 65. For a well-built person, the systolic BP less than 90, and signs of impaired organ perfusion. So patient coming in with altered mental status, cold clammy skin, oliguria, and raised serum lactate levels. These all are the diagnostic criteria for any kind of shock. Okay, for specifically for a cardiogenic shock, the patient can have a increased crepitations, a pink frothy sputum as we label for a pulmonary edema. Okay, these all comes under your diagnostic criteria. So as the physical examination, they could have creps all over and raised JVP, and there can be any murmurs. Okay, so we have, in case of cardiogenic shock, you also have to look at the ECG and look for signs of ischemic changes. So echo to look at the ejection fraction, valve motion abnormality, dilated RA and RV, and the valvular dysfunctions, anything you need to see, and mostly the lung ultrasound for any B lines. Okay, so in case you find a STEMI in your ECG, go for immediate cardiac revascularization procedures. Okay, so in case of any you find any pulmonary embolism, go for thrombolytics. And so in case of hypotension in this type of patient, as I've already told you, if the BP is above 90, go for dobutamine. And if it is less than 90, start about noradrenaline and then go for dobutamine. And if you find the heart rate is very less and the patient is in a complete heart block, you need to think about starting on atropine. And then if even there is no response for the atropine, you can go for adrenaline infusion and dopamine infusion also. So these are the inotropes, which is mostly used for your cardiogenic shock, which is your dopamine, noradrenaline, adrenaline, and milrinone. So we restrict the use of milrinone, okay, because this also requires the BP to be on the higher side, and only then we can use this. So next comes your distributive shock, which is the most common shock which has been present. We daily encounter. The most common is your sepsis and your septic shock. So sepsis is a life-threatening organ dysfunction caused by dysregulated host immune response to an infection. Okay, so most common thing is your gram-negative sepsis, which will go to a septic shock. Okay, so the most common scoring system we use to find out sepsis immediately is your Q-SOPA scoring system. So anything which has a scoring system of more than 2 will tell you that the patient is in septic shock, which means the patient can have either hypotension with BP of less than 100 or an altered mental status with GCS less than 15, or if the patient is tachypnea. Out of these 3, any 2 is present, we label the patient as septic shock. So this is the very easier way to find out. Within seconds, we can use a Q-SOPA scoring system and you can find the sepsis and septic shock. So next thing is in sepsis is your most common thing which we perform in the emergency department is a 1 hour bundle, which means we need to finish everything within 1 hour. So we need to get the blood samples from the patient to look at the ABG and to measure the lactate levels. So next, while placing an IV line, we get the ABG samples and also the blood cultures. Immediately start off with the fluid resuscitation, usually 30 ml per kg per hour. Okay, so that is what we usually follow. And then we administer any broad spectrum antibiotics depending on the history, where the patient is the source of infection. Depending on the history, we start off the broad spectrum antibiotics immediately. So then in case the patient is not responding, within 1 hour, we cannot tell whether the patient is responding to it or not responding to it. So fluid resuscitation and then administration of vasopressors is also within this 1 hour should be our initial goal. Okay, so this is the 1 hour bundle in any sepsis. So starting even vasopressors comes within the first 1 hour of management of sepsis. And it should begin immediately as patient enters your hospital. Okay, so next comes your neurogenic shock. In a neurogenic shock, it is mostly because of the unopposed parasympathetic activity, which leads to massive vasodilation. Okay, so in case of any spinal cord injury above the level of T6, okay, so the most important causes is your trauma, injury to your cervical and your upper thoracic spinal cords. And in case of a regional anesthesia also, you can get a neurogenic shock and severe brainstem injury. So how can you easily identify a neurogenic shock? Any patient who has got a trauma and who has got hypotension along with a bradycardia. So, and they would have a warm and a flushed skin. That's very common. So recently we had one trauma in our hospital where she was a young girl who had a rollover by a four-wheeler. So this girl presented to us with absolutely GCS was completely fine. Her GCS was around 15/15. And if you look at her heart rate, it was around 40/45. And she had arrhythmia, which means she had ventricular premature complexes like a bigeminy. Maybe every second complex was a premature complexes, and it was a bigeminy, and she had hypotension also. So we looked at everything. She was able to move all four limbs, but still when this was there, we had a suspicion of neurogenic shock, and we did MRI, and which showed a dissection at the level of C1 and C2 level, and there was also a thrombus. So this was at the celiac trunk. So that's why she had arrhythmia. So this is any trauma, we should also think about who's got a bradycardia and hypotension. We also should think about a neurogenic shock. So that was a key important learning. So difference between, we know what is a spinal shock and a neurogenic shock. So this is usually a temporary loss. Neurogenic also, this is sudden loss of sympathetic nervous system. So both of them will have a hypotension and bradycardia. Okay, so this the most important mechanism here is your total power would be lost in a power, sensation, and reflexes. Everything will be lost in a spinal shock. But in a neurogenic shock, it only the sympathetic nervous signs would be lost, that they would only present to you with a hypotension and bradycardia. Okay, so that's how you difference between this is a standard dermatomal level, so where you could see the losses and you can identify which thing is involved. So next comes in your anaphylactic shock, in your distributive shock. So there are two terminology. So allergic reaction. Anybody who's got a bee sting, who's got rashes, redness, we term them as an allergic reaction. Whenever any of the problems like your airway, breathing, and circulations are involved, that time only we call it as an anaphylaxis. Okay, which means rapidly developing life-threatening problems along with a hypersensitivity reaction. So any threat to the airway, breathing, and circulation. So they can have a laryngeal edema, they can have a bronchospasm, and they can have an hypotension along with the tachycardia. So along with this, they can have features of allergic reaction like urticaria, angioedema, and these can also call, whenever any allergic reaction is associated with airway, breathing, and circulation problem, we term them as anaphylaxis. Okay, then is your anaphylactic shock, when they present to you with a hypotension along signs of anaphylaxis with a shock. It's called as your anaphylactic shock. I hope the terminologies are clear. So we know the management is to keep the airway patent. So whenever you know the patient is having a airway threat, definitely we first think about intubating the patient or get his airway secured. Next is giving him a good oxygen supply and give him nebulizations to prevent the bronchospasm. So the drug of choice for your anaphylactic shock, as previously I've already told, it is your adrenaline, which is IM. Okay, so everybody knows IV has more has got increased action when compared to the IM. So, but in case of anaphylaxis, why do they tell IM as the choice of administration? Because it is not that IM has a faster penetration. It is only because the time we spend in finding an IV line becomes a little longer. That's why they say give the adrenaline as soon as possible. Okay, so the most possible way is to give as an IM dose. If you have an IV line, it is better, but you should not understand, you should not give it as a bolus. If you give it as a bolus IV, they will have arrhythmias. The problem by giving through the IV bolus is it's still the 0.5 mg should not be given as a IV bolus. You should understand that 0.5 mg is only for IM dose. When you're giving it as an IV dose, you have to dilute it multiple times and then only give it as an IV dose. Since I've told while we have an IV line, you give it as an IV. If you give it as IV, you will have a lot of arrhythmias. So if you have 0.5 ml, 5 mg is easier to take and it's easier to give it administered through IM injection, IM way. So that is why we say it is easier to give in an IM way. Okay, so the dosage for different ages differs. We also provide IV hydrocortisone 100 mg as a stat. And if we want to give, you see a patient with anaphylaxis, treat them with adrenaline, hydrocortisone, and all. And then you plan to observe the patient for 6 hours, and then you plan them for a discharge. So during the discharge, we give them dilprednisolone at least for a week, and then we discharge them. Then is your antihistamines. So with the antihistamines, you can give, we usually prefer to give avylclofenaramine, and or we can even go for Rantac, H2 blocker as your IV Rantac. Okay, so even it is not responding, the hypotension is not responding, then we can go for IV glucagon. Okay, so this is your management for you. Okay, so next we are coming into the other aspect of a shock, which is the most important, and we are all evolving with the ultrasound. Okay, so the most see, none of our examinations are going to help us. So even for getting a CT or mobilizing a patient for any kind of investigation, it takes a lot of time. So the most commonly readily available instrument nowadays in most of the hospitals is your ultrasound. Okay, so how do we deal with the ultrasound to find out a shock, and how do we treat them is very, very important. Okay, so we follow, as I've already discussed you, with a pump, tank, and a pipe. So the same way, I'm going to demonstrate how to find the shock by using a rush protocol and the ultrasound. Okay, so we have something called as the rush protocol, which is usage of rapid ultrasound in shock. Within seconds, you can find what type of shock it is, and then you can also initiate the treatment. Okay, so first thing is your pump. Okay, so in the pump, I am more worried. I will talk to you about each and everything, and then at last we will discuss. So this is your pump, tank, and pipe we are going to deal with. Okay, so pump means, as I've already told you, it is your heart. Okay, I need to look in the heart. These are the probe position. The most common probe is a cardiac probe, which I use to look at the pump. I can also use my curvilinear probe. Okay, so whenever I am looking at the pump, I will use the cardiac probe. I can keep in the probe position A. It is mentioned here. Can you see? So while keeping it in facing the right shoulder, I tell it is a long axis, and then turning the probe, there is a probe orientation. Every probe will have a marker in it. Okay, that is called as a probe orientation. Okay, so when you hold the probe marker on the right shoulder, so if there's a marker here, the side of the probe, there will be a marker. And if that probe marker is pointing towards your right shoulder, which means your long axis, and when you twist it, which means your short axis. Okay, so with this, you can have the view of the heart, and with long axis and short axis parasternal. Okay, then you can view the heart as a whole, and you can know if you have any pericardial effusion. Everything is a contractility is good. Everything we can look into. So all four chambers you will be able to view. Then is your subxiphoid view, which is your B. Okay, in a subxiphoid view, we can also still see the four chambers. So by seeing this, what we can find? So we can find out whether the patient has gotten a cardiac tamponade or not, whether the RV is collapsed or not, or if the RA-RV is dilated or not, or if there is any myocardial hypokinesia of the walls or not. Okay, so then is your apical view. So all three views are useful in locating your heart and looking at any problems with your heart. Okay, so this we will see. So it is a typical four-chamber view to look at the surrounding the heart. So which is a pump dysfunction. So looking at this is your pericardial effusion. Okay, so in this you can, if the blood is little altered, it is in a slight grayish position, we will know it is a clotted pericardial effusion. Okay, so next one will be your to look at the RV compression. Okay, so this and a fluid is around the heart, it's a pericardial effusion, and if it is compressing the right ventricle, we tell it is a cardiac tamponade. Okay, which needs immediate pericardiocentesis. So the treatment for the shock is only treating the condition which is producing the shock. So you need to do the pericardiocentesis for this patient. So next one is your RA and RV, which is dilated, which is your pulmonary thromboembolism. Okay, so for this, you need to treat accordingly. Okay, so this will help you know whether what is a pump is involved in your cardiogenic shock. Okay, so to know your cardiogenic shock, we use this pump with the ultrasound. Next, we are looking at the tank. Okay, so in the tank, the most important thing is your intravascular volume, which I wanted to see. So even for fluid resuscitation, we look at the IVC every time. Okay, so based on the IVC only, we even decide on whether to give the fluids, stop the fluids, or whether to even continue the fluids or not. How much of mLs of fluids we wanted to give, we decide based on the IVC nowadays, because we don't know which is this fluid is sufficient for him or not. It's dependent mostly on the IVC volume. So the tank will tell you the intravascular volume which is needed. Okay. So again, so first thing which I'm going to see is your proposition A. This is a position where I'm going to look at my IVC. Okay. So the probe orientation is towards the cephalad. Okay. Looking at the patient. So this will tell me whether the IVC is compressible, non-compressible. I will show you the pictures next. Okay, so I'm just compressing it in the xiphoid region and looking at whether the IVC is compressible or not. Okay, in this position I can see the IVC, or I can even go to the right hypochondrium region from the point where it leaves the hepatic vein. From there also I can trace the IVC to check whether it is compressible or not. Next position is your right hypochondrium, which is your fast position, right upper quadrant. Okay, this will tell me if there is any fluid in this space. Okay, anywhere a fluid collects. So this is for position A is to look at the IVC and give the fluids. Okay, so position B is to look at any free fluid in the abdomen. For example, a patient is having a ruptured ectopic. The patient would definitely have a hemoperitoneum, and the fluid and the blood will first get collected to your right upper quadrant. Okay, so the first place your fluid gets collected is your right upper quadrant. So any ruptured ectopic you can see. So or even in trauma. So the most dependent position is your right upper quadrant. The first position to check for any fluid loss is your right upper quadrant. Next position is position C, where left hypochondrium. So splenorenal angle. Where you have to see is your, in the right side is your hepatorenal angle. If you keep your probe in the mid-axillary line, you can see the liver and the spleen together. So I will show you a picture. I cannot hear. So if you keep your probe, you can see the liver in the mid-axillary line. You can see the liver along below, you can see the renal. So if any fluid is collecting in this space, okay, so between the liver and the renal, we call that there is a fluid which has been accumulating. Okay, so this will tell us whether it is whether there is a free fluid in the abdomen or not. Next one, as I told you, proposition C, to look at your left hypochondrium. There also splenorenal angle you have to see for any fluid collection. Next is your pelvic region, to look out any fluids in your pelvic region. So around the bladder, you have to look into. Next is your lung position, to look for any B lines. If there are any B lines, that will suggest you of a pulmonary edema. Okay. So and also if you if this we also look at something called as a sliding. If the sliding is present, it means there is no pneumothorax. If the sliding is absent, we tell there is a patient has got a pneumothorax, and we'll have to go about needle decompression or an ICD placement. Okay, I think this tank has been little clear. So this is the IVC assessment, as I've already told you. So when you see, whenever you keep your probe, there will be before inspiration, the IVC looks to be a little dilated, and after inspiration, it will be compressed. So when the IVC is compressible after inspiration, then we call it as a collapsible IVC. But both are before inspiration and after inspiration. If the IVC is dilated, we tell it is a dilated IVC, and we restrict the fluids. So it is not like completely cutting off fluids. We can limit the fluid resuscitation. Come down on fluid resuscitation. So now, so whenever the patient has got, as I told you, you have given the IVC is completely full, and whether now you need to know the still patient is having a kind of still in shock, but you feel that still more fluids can be given. So this will depend upon looking at the B lines in the chest. The proposition which is put in the chest in a longitudinal view, we can see for B lines. If there are B lines, we can stop off the fluids, and we can even proceed on with Lasix. And if there is no B lines, you can give some more fluids. So then we come to the pipe. Okay, so this is the vasculature. So in the pipes, we are mostly dealing about with their multiple positions. We are probe A. So looking in the pipe is mostly dealing about with your dissection, DVT. This is all is being dealt in with your aneurysms. It's all dealt in with your pipes. Okay, so looking at the suprasternal aorta. So for looking for any dissection. Okay, so even intersection patient can have they can have both high BP and a low BP also. Okay, so initial when it is not ruptured, they can have a high BP. When it's ruptured, they can have an hypotension. Okay, then the probe position at B to look at the parasternal aorta and the epigastric aorta and the supraumbilical aorta, and then the femoral region and the popliteal region to look for the compressibility of the veins, to look for any DVT. So this also will rule out your hypotension shock process. So this is how your dissection looks. You can look at the aortic root, how big. If it is more than 5 centimeter, we tell it is a aortic arch dissection. Okay, so this is your abdominal aorta. If you see, if it is more than 3 centimeter, it is dilated, we tell it is it's got an aneurysm. Okay. See, these are the positions. You look for compressibility, but we are most commonly looking into the femoral and the popliteal veins. So we can sometimes we even trace it out from the femoral region. So, but the most commonly we look for compressibility is in the femoral and your popliteal. So this is putting everything together, the pump, tank, and the pipe. Okay, so you can look into the long axis view, how does it look like, and a short axis view, the LV, how does it look like, LV cavity, how does it look like. So looking for any hypokinesia can be looked in here, and the four-chambered apical view will tell you whether the RARV is dilated or not, and then your subcostal view will also tell if there is any pericardial effusion or not. Okay, so then you come about with a tank to look at the IVC. So this, they have shown you the in the right hypochondrium region, the tracing of the IVC, as I've already told you. And here is looking at the B lines and your sliding. Okay, so this is the pulmonary, look into any effusion. So right hypochondrium, I have told you, hepatorenal angle to look at any effusion or any blood products being collected. So here is your splenorenal angle, and then looking into the bladder in the sides to look if there is any blood loss or not. Okay, then to the pipe, the abdominal aorta to check the diameter of the aorta, and then the compressibility of the femoral vein and your popliteal vein. So this, as a single slide, tells you the rush protocol. So are we ready for the questions? I hope I'm clear. So you can all unmute and you can answer. So we have a 55-year-old male with an RTA and a crush injury. He had a two-wheeler versus four-wheeler and was brought to ER with a low GCS. So GCS is around E3, B3, and M5, which means he is eye-opening to even verbal responses, and he's having some sounds, and he's localizing to pain. His heart rate 166 and his BP is 80/50. His respiratory rate is 55 and his saturation is 80% in room air. So what type of shock is this? Can someone answer?
Hypovolemic shock.
Okay. Why do you say it is hypovolemic shock?
Because there is tachycardia, the BP is low, and there is a history of crush injury. So
Okay.
that is suggesting that maybe he has lost a lot of volume.
Okay. So, but can a hypovolemic shock have a drop in the saturation level?
Matlab, there may be some crush injury of the ribs also. So
Yes.
that's why,
Yes.
matlab, flail chest or something must be there.
Yes, yes. So when you should always not only go into the vitals, you also look into the history. So there can be two shocks which can be overlapping on one another. There could be an obstructive shock and a hypovolemic shock together. So the respiratory rate is 55. Okay. So, and the saturation is 80%. So I would use my ultrasound to find out if the patient has got a good sliding or not, to look for any pneumothorax first. If there is a pneumothorax, my priority is to treat the pneumothorax first and then go for the fluid resuscitation or blood volume resuscitation. Okay, so you are definitely right. It could be a hypovolemic shock. Just to put you into little confusing question, I asked, why can't it be a pneumothorax and any other respiratory problem? So shock need not always be a single shock. It can be two or three shocks together. So a septic patient can also have a Takotsubo cardiomyopathy, and they can also have a cardiogenic shock. It can be overlapping. So this one, a 67-year-old male who is a CKD presented to the ER with breathing difficulty, has missed his due dialysis yesterday. Okay, so now he comes to you with a GCS of E3, which means he is eye-opening to your call and eye-opening to pain. So, and he's speaking to you and he is obeying your commands. His heart rate is 30 and his BP is 80/50 and his saturation is 80% in room air. What type of shock is this? Anybody? Anybody there? So a CKD patient?
Cardiogenic shock.
Yes.
Cardiogenic shock.
So, so how do you treat about this
Okay.
patient? How do you treat about this patient?
First, it went bedside echo.
Okay. So I've done an
Mhm.
echo, which is showing, see, whenever the heart rate is 30, you definitely, the contractility
Do an
will be
ECG
very poor.
also. Yes.
I do an ECG, which is showing a complete heart block.
So vasopressor support should be started immediately, and
So this,
along with
So
we have to give
this is
isoprenalin or
this is a CKD patient. We should see the electrolytes also.
yes, very good. That's a key important point here, which I wanted to put into trouble.
hyperkalemia can be a cause. Okay.
Yes, yes. Hyperkalemia could cause you a decreased heart rate. The patient ECG can tell you the patient has got a complete heart block. But when you look at the potassium, because he missed his dialysis, okay, his potassium can be to the roof. It can be up to 8. Okay, so until you treat the potassium, your heart rate is not going to become normal. Okay, so this was a patient we had just 2 days before in our ICU who came in with breathing difficulty, who has missed his dialysis, and his potassium was to the roof of 8. Okay, so immediately we started all the hyperkalemic measures and we gave him a shot of dialysis. So we started, but we cannot miss the heart rate also. He's showing a complete heart block. I cannot see, I have to definitely treat the heart also. Okay, so that when the high potassium, that can also cause myocardial ischemia, that can even lead him to a death. So we put him on a temporary pacer pads in the ER. We paced him and we simultaneously started the hyperkalemic corrections. So he was shifted for a dialysis. Dialysis was done. The next day, the heart rate became normal. It showed a sinus rhythm, and the potassium kept falling. So he didn't require a permanent pacemaker. Temporary pacing was done, and hyperkalemic treatment was also initiated simultaneously. So this is way whenever we have we should know about the patient history also, what we are dealing with. Okay. So next, we've got a 16-year-old female who has got a bee sting followed by swelling of the face and drowsiness. The heart rate is 135, respiratory rate is 26, BP is 60 query. So this
Allergic
is,
or anaphylactic.
yes,
anaphylactic
this is
shock.
very, yeah. So this is very easier to find it out. I'm not putting any twist in this. So how do you treat this patient?
Subcutaneous adrenaline. IV hydrocortisone and
IV
AM
hydrocortisone. IM adrenaline.
I
Okay,
am
so
adrenaline.
IM
I
adrenaline, and then you can start off with your fluid resuscitation. So
fluid
you give
resuscitation
one IM adrenaline you give, and it is not responding. So next, what do you do?
Then IV hydrocortisone and fluids.
hydrocort or
Yeah.
prednisolone, methylprednisolone up to 125.
So both the steroids together the same effect. You can either
Yeah.
choose
No,
only for
either
discharges. You can use metalpred. So hydrocortisone is fine. Then
Diphenhydramine also.
you give everything. You give your Avil, Hydrocort, you give your adrenaline, you give off fluids. So even then the BP is still on the lower side. So next, what do you? You can even give top up with another shot of adrenaline IM. 3 times you can give adrenaline IM. Even after the 3 times, if the patient is not responding, then you can go for adrenaline infusion, but not adrenaline as bolus. Okay. So any other doubts you have? Okay. So this is a 55-year-old patient who has got a CAD, presented to the ED with hematuria since morning. Okay. His GCS is 15/15. His heart rate is 120 and BP is 80/50. And his respiratory rate is 21. What type of shock is this?
be hypovolemic.
Hypovolemic, yes. Then any other? Can it be having any other shock to it?
Can be septic shock also.
Septic shock
Yes,
can be.
it can be septic and hypovolemic also. Both can be there. So how do you treat this patient?
Fluid
So how do you treat
resuscitation
this?
and blood transfusion if needed.
Yes,
Do
blood
a ECG.
transfusion. Yes. So absolutely, he's a known CAT. You should definitely be on aspirin or clopidogrel. So that would cause him a hematuria. So he can also have a pyelonephritis, which is producing him a hematuria. So both are possibilities. So whenever we look into hematuria alone, we should not only think him on transfusing him blood. Okay, we should also think that she might also have a sepsis component and treat him with antibiotics to deal in with the pyelonephritis part. Okay, so there is not we have never seen a single shock always presenting alone to us. So always whenever we are in shifts, we always have multiple shocks on top of each other. So think about multiple possibilities and try to cover all your treatments together. Okay. Okay, the lecture is done. So I would be happy if you ask me some doubts for the day.
Thank you, ma'am.
Thank you. So any doubts?
Any questions? We are happy to
For
answer.
for for cardiogenic shock,
Yes.
do we always have to check PCWP, or it's only in the higher tertiary centers we have to?
Okay. So for a cardiogenic,
Now, 1 minute. What is the
Ah.
difficulty in checking WP? Why you need to shift the patient for higher center?
PCWP for checking if it is cardiogenic shock.
Why you want?
I was asking, is it necessary?
No. Anywhere Dr. Arthi has mentioned pulmonary wedge capillary pressure. Last session also I told pulmonary artery wedge pressure is outdated. So now we are having a ultrasound. Okay. With the
Okay.
ultrasound, we can able to identify, try to use more non-invasive rather than invasive. Again, it has a lot of fallacies. I have done more than 50 patients with pulmonary artery wedge occlusion pressure. Okay. So, but it is really very technically challenging, very difficult, and very expensive, and it doesn't give much information.
Okay.
Usually we can do, and now there are centers, even our centers, we have a pico monitor. So pico monitor, just putting the patient just between the pico monitor, we are able to identify the continuous cardiac output. Okay.
So thank you, sir.
yeah, sir told we have other many non-invasive machines like your ultrasound. So that will more easily pick up for referring a patient. We can treat the patient in our own setup.
After we have given the doses in an anaphylactic shock, how do you manage the patient? Like suppose the patient BP has started rising. How many hours should we keep the patient for observation?
See, any anaphylactic reaction will have a biphasic reaction. So they should be definitely under observation for 6 hours. That is mandatory. Even their BP picks up. So 6 hours of definitive observation in the hospital is mandatory. If they try to leave before that, you need to get an against medical advice sign. Because they can have a biphasic reaction. So anytime that can even may drop the BP still, okay, during the biphasic reaction. So even after the BP is picked up, definitely for 6 hours, they need to have an observation in your hospital.
After 6 hours, we can safely discharge the patient.
Along with the steroid dosage.
Yeah.
As I mentioned, the
Oral
methylpred dose.
steroids, yeah. Thank you,
Yes,
ma'am.
oral steroids for 7 days. Okay,
Okay.
but this doesn't require tapering of dose. You can just continue 1 mg per kg for 6 days OD, and then you can discharge them along with Rantac and your Avil.
Okay. Thank you, ma'am. Thank you.
Yeah.
One more point to add on the anaphylaxis. It is not that 6 hours, it depends on the severity. Okay. Even in some institution, they admit for 24 hours. Some institution, they have a protocol for 12 hours. Again, depends on how the patient is educated and the patient is nearby to the hospital. As Arthi has rightly pointed out, it is a biphasic reaction, and we also call it as a rebound phenomenon. Rebound phenomena is very, very common in anaphylactic shock. So once they settled with their shock, there is always chance when the adrenaline effect is over, they may have it. So it is always advisable. We need to be very cautious in discharging the patient with anaphylaxis. And insect bite anaphylaxis, always check for CPK total. We have ultimately landed one of our colleague practicing in Andhra had seen a patient with a vaccine anaphylaxis. He treated anaphylaxis. Second day, patient was discharged. And fourth day, patient readmitted with acute kidney injury, underwent dialysis. Okay, so probably it is because of shock-induced kidney injury or myoglobinuria causing increased CPK total causing acute kidney injury or not. We don't know that. But the patient had this, and the patient once recovered, they filed a suit that the patient has not been advised to monitor for the renal function and other such things. And still the case is there in the consumer forum. So whenever you are discharging, please mention that there is always a risk of acute kidney injury is there. If there is a decreased urine output, immediately ask them to report to the hospital.
Thank you so much, sir. Thank you. That's a very good thing you have pointed out. I'm very thankful.
Any other questions?
Anything else? Any questions?
Dr. Neela Kumari has asked the restrictive fluid strategy in shock management. Yes, it is a good question. There is always a debate going between the liberal versus the restrictive. Okay, so they had a trial. One is called as a petal trial versus flowers. That is crystalloid liberal or vasopressor early resuscitation in the sepsis. That was the trial name, flowers trial, and they found that there is no much difference. Okay, it is based on our clinical acumen, how they are being patient presenting to the emergency room. So if you are using a restrictive fluid strategy, that means early you have to start vasopressors or inotropes. Okay, whereas in a liberal we give a fluid almost 2 liters or 3 liters. In a liberal, again we have to watch for the volume overload, coagulopathy, hypothermia, etc. In a restrictive, there is always chance of acute kidney injury is there. So you need to be cautious, but never use colloid. Okay, even in a restrictive, you should not use colloid. Clear?
So one more question I would like to ask. So a 66 years old patient admitted to ICU with ischemic cerebrovascular accident, right MCA territory. It was on day 2. He's been admitted, and he developed subsequent developed urosepsis. Was diabetic patient was known diabetic for last 10 years, and the BP was persistently below around 80/40, and subsequently developed hypernatremia. The sodium level was around 167. So in that case, we have what fluid strategies should we adopt to treat the septic shock, to manage septic shock, as well as we can consider to manage the hyponatremic episodes. Patient was hypoglycemic in 2 episodes before admission.
So hypotension itself tells you that the patient has been in sepsis before itself. Okay, so this patient, right antibiotic choice early, and initially you wouldn't have been hypernatremic. So initially you would have either normal sodium levels, or you would have, by giving lot of fluids, he would have gone for a hypernatremia, which landed up to a sodium of 167. At present, you have to treat him with 5% dextrose or a free water, and there is no role for half normal saline here, and 5% dextrose. And if the sugars, as he already told, the patient would be in hypoglycemic. Okay, so you told, so if he is hypoglycemic, 5% dextrose. Even if he is hyperglycemic, you can use an insulin infusion and give a 5% dextrose to reduce the sodium level, and a free water and appropriate change of antibiotics.
Arthi, actually, this patient had a CVA, ischemic stroke.
Okay.
So
Yes,
here,
yes, ma'am. That's it.
we should not use 5%
Okay.
dextrose.
Okay.
5%
Oh,
dextrose. Here, the hypernatremia itself, an indication there is a fluid deficit is there. Okay.
yes. Yes,
So
yes,
you
yes.
have to give fluid, and you have to make the patient as euvolemia. So once euvolemia is made, then we can check for the hyposodium level. If it is hypernatremia, hyponatremia, or eunatremia, isonatremic, then
Yes, yes, yes.
target
Osmolarity. Look at the osmolarity.
Here the fluid
and
of choice would be normal saline or ringer lactate. What fluid we should prefer opt for initial management?
Sir, for initial management, ringer lactate is better. Last class, I clearly mentioned it is not a
Nice.
normal
Yes,
saline,
sir.
normal saline. Okay, no
Okay.
normal saline should be used in resuscitation, because resuscitation for using normal saline is only in hyponatremic, hypovolemic condition only. You have to use normal saline. Otherwise, don't use anywhere. The resuscitation fluid here is only ringer lactate.
Okay, so then maintenance fluid, should we consider for normal saline or
You
for
can use
until
half NS you can be using, or if the patient is adequately resuscitated and still the patient, you feel that patient is hypernatremia, then you can give a free water. Normal free water can be given through the Rice tube.
Okay. Okay, so we have also checked the IVC collapsibility. It was around diameter was around 1.225 and was flush stability index was also around 50%. So patient was definitely needs fluid initial hypovolemic state initially.
Whenever there is an hypernatremia, unless otherwise proven, it is a volume deficit.
Yeah.
Okay, just you give the volume, then you check, recheck, then we can think about other maintenance to it.
Okay. Okay. Thank you.
So if no questions there, then
Sir,
we
I have another question, sir.
yeah, please. Arthi.
Sir, regarding that case that was severely dehydrated, no, sir. That is the reason for dehydration will cause hypercoagulable state, and that may cause CVA, no, sir. Is that possible, sir?
Sir,
Yes.
theoretically it is possible, but not dehydration per se causes hypercoagulable state.
Okay, okay. Hemoconcentration and that cause
Concentration might be there, and that would have caused rather than coagulability. And even hypotension can cause watershed infarct.
okay, okay.
So if you see the CT pattern, you can see the multiple watershed reason is there. Then it means that the patient is having a hypotension, and because of hypotension, there may be a ischemic insert.
Okay. Thank you, sir.
So
Anything
thanks
else?
for your patient listening. Thank you. Thank you, Arthi.
Thank you. Thank you. Thank you everyone for your patient listening. Thank you, sir.
Thank you, sir.